Welcome back. We're going to talk about management of gout in this section. In last section, we talk about how to make diagnosis of gout. In this section, we'll talk about chronic prophylaxis of gout, and then we will talk about management of acute gout. So we'll start with a question. Question number 1. We have a 45-year-old Caucasian male patient. He has no symptoms. He tells you that he has a history of gout for last 5 years, and he also has a history of hypertension. In last 5 years, he had only one attack of gout. He take NSAID, PRN, and he's on losartan for high blood pressure. You do blood workup, his comprehensive metabolic profile is normal. His serum uric acid level is 5. His X-rays are normal. He has no tophi on examination. What would you do for this patient? Option A, start him on allopurinol. Option B, start him on colchicine. Option C, both A and B. Option D, DC his losartan and start him on hydrochlorothiazide. Option E, recommend him lifestyle modification. So here the right answer is option E. We will offer him lifestyle modification. So ACP recommend against initiating urate-lowering medication in most patients after a single attack. So if patient have a single attack, if they have a history of CKD, if they have chronic gouty arthritis, or if they have tophi on examination or renal stone, you can justify starting them on chronic prophylaxis treatment. But if they just had a single attack with no comorbidity, we don't like to start them on chronic prophylaxis. So option A and B are incorrect. What about option D, DC losartan and start him on hydrochlorothiazide? So we're going to discuss that concept in next slide. So diuretic, hydrochlorothiazide and furosemide or Lasix, they compete with uric acid at the level of PCT. They compete with this organic anion transporter. So uric acid is secreted at the level of PCT through these transporter. So if you give them hydrochlorothiazide or furosemide, they're going to have increased uric acid reabsorption in their blood, and they can have increased gout attack. So that's why we don't like to give them diuretic therapy. This is one concept. The second point is diuretic can cause volume depletion, which can cause acute gouty attack. Now, patients who have a gout, 10% of patients produce too much uric acid. Most of the patients have gout because either they have a CKD or they have a genetic defect at the level of PCT. It means they are reabsorbing too much uric acid at this organic anion transporter. So if you give them diuretic therapy, they're going to reabsorb more uric acid and they're going to have more gout attacks. So that's why we don't like to give diuretic therapy. So let's talk about what losartan do, why we were giving patient losartan. So in this reaction, this is the terminal reaction for uric acid synthesis. So hypoxanthine and xanthines are converted into uric acid with xanthine oxidase. Now, uric acid is excreted in the kidney. Now, these drugs, probenecid, losartan, fenofibrate, estrogen, they enhance uric acid excretions. Okay, so that's why we like to give losartan. Losartan is a drug of choice if patient have hypertension. Okay. Now, what about estrogen? So there are two types of gout. One is typical gout, which happen in younger male patient. It is uncommon in female. Typical gout is uncommon in female because estrogen enhances secretion of uric acid. Okay. After menopause, female patients also have increased risk of gout. Typically, they have atypical gout. They have multiple joint involvement. Okay. So let's talk about lifestyle modification. So patients who have a gout, we should tell them calorie restriction diet. They should have increased proportion of protein from low fat dairy product. Studies have shown this decreases the uric acid production. you replacement of refined with complex carbohydrate. Patients should not take too much fructose. Studies have shown too much fructose compete with metabolism of uric acid, so they can have increased uric acid, increased gout. They should decrease saturated fat, and they should decrease alcohol intake. Now, alcohol can exacerbate gout with three mechanisms. Number one, alcohol consumption can lead to production of lactate, which can compete with uric acid secretion at the level of PCT. The second is alcohol is a substrate for purine synthesis, so purine can lead to more uric acid production. And the third point is patients who drink alcohol, they can get dehydrated, that can cause gouty attack. Now, losartan has a uricosuric acid effect. It increases the uric acid secretion we already talked about. Let's do question number 2. The last patient, who was a Caucasian male, he was on lifestyle modification. He came to your office. He is asymptomatic now. He tells you that in last 1 year he has 4 to 5 attacks of gout. You check his comprehensive metabolic profile, it is normal, but his serum uric acid level is 9.6. It has gone up. His serum uric acid level was 5. What would you do for this patient? Option A, start him on allopurinol. Option B, start him on colchicine. Option C, give both A and B. Option D, give him Fiboxy Stat, which the trade name for this medication is Uric. So here the right answer is option C. We'll give him allopurinol and colchicine. He qualifies for chronic prophylaxis. Patients who have more than 2 attacks, we like to give them chronic prophylaxis. Okay. Now we give allopurinol for chronic prophylaxis, and colchicine we will give a shorter duration. We'll talk about that now. So why did we pick allopurinol in this patient? Why we did not pick Fiboxy Stat? So let's talk about that. Now, allopurinol is the drug of choice, is the first line of treatment for Caucasian patient. Fiboxy Stat is very expensive. It is not a first line of treatment. We consider Fiboxy Stat if patient have side effect with allopurinol. Allopurinol was FDA approved for gout in 1966. Fiboxy Stat is a recent medication. It was FDA approved in 2009. Now, why? When would you pick Fiboxy Stat instead of allopurinol? So patients who are Asian, who have patient from China, Korea, Thai, Japan, they have increased risk of having allopurinol induced drug reaction with eosinophilia. They can have DRESS syndrome. The reason these patients can have DRESS syndrome, they have a variant called HLA-B5801 variant. This variant is common in Asian patient and African American patient. So Asian patient, if you give them allopurinol, they have 12 times higher risk of having allopurinol hypersensitive syndrome, and in African American 5 times more common. So if you have a genetic test available, you should check them for HLA-B5801 variant. If you do not have that test available, you should pick Fiboxy Stat instead of allopurinol. So what happens in DRESS syndrome? When you give patient allopurinol, these patients can have fever, maculopapular rash, they can have lymphadenopathy, and it happens in approximately 2% patient and 25% mortality. Okay, but it is uncommon in Caucasian patients. So our patient was Caucasian male, we can justify giving him allopurinol. So there are 4 indications for giving chronic prophylaxis with allopurinol. Number 1, patient who have more than 2 attacks in 1 year. Our patient had 4 to 5 attacks in last 1 year, and his uric acid level was very high, so he qualified for chronic prophylaxis. The second is if patient have clinical or radiographic evidence of chronic gouty arthritis. The third is if patient have tophaceous on exam. Number 4, if patient had a 1 attack with GFR less than 60, we can justify giving them chronic prophylaxis. Okay. So urate-lowering medication, so there are 2 types. One is xanthine oxidase inhibitor. So there are 2 types. One is allopurinol. We start with 100 milligram and we titrate it up to in 2 to 4 weeks our goal is to keep patient uric acid level less than 6. So the second medication is Fiboxy Stat. The mechanism of allopurinol and Fiboxy Stat is kind of same. Fiboxy Stat, we don't have to titrate it. You start with 40 milligram of Fiboxy Stat. If their uric acid do not improve, you can go up to 80 milligram. 40 milligram of Fiboxy Stat is equivalent to 300 milligram of allopurinol. We give Fiboxy Stat to African American patient, patient of Asian origin, or if patient is taking allopurinol, if they are having GI toxicity, we give Fiboxy Stat. Now, when you give these chronic drug, these can fluctuate the level of uric acid and which can cause gouty attacks. So in order to prevent that, you give colchicine or NSAID for 3 to 6 months. So that's what we did for our patient. We started him on allopurinol and colchicine. Now, patient who have a CKD, rather than giving 100 milligram allopurinol, you can justify giving them 50 milligram. They will have less side effect. Most of the patient who have gout, they need 300 to 450 milligram of allopurinol to bring their uric acid level less than 6. So we want to keep level less than 6 because gout happen if patient uric acid level is more than 6.8. More than 6.8, patient can have crystallization which can cause gout attacks. So we want to keep their level less than 6 because uric acid level fluctuate a lot. So why do we give NSAID therapy, colchicine, and sometimes we can also justify giving less than 10 milligram of prednisone. So the concept is iceberg phenomena. So when you give allopurinol or Uric, it will lower the serum uric acid which can fluctuate, and now patient have uric acid in their joint which will release from joint. It will go to systemic circulation which can cause acute gout attack. That is the logic behind giving colchicine or NSAID and rarely less than 10 milligram of prednisone for 3 to 6 months along with chronic prophylaxis. Let's do question number 3. Our patient is on 450 milligram of allopurinol and colchicine. So he's on a very high dose. He came back after 9 months. You check his uric acid level, it is 5. You checked his uric acid level 3 months ago, it was in the range of 5, which is pretty good. So he's at his goal uric acid level. We want to keep level less than 6. He tells you he has not had any attack for last 9 months since we have started him on medication. On exam, he has no tophi. What would you do? Option A, DC allopurinol. Option B, DC colchicine. Option C, DC both medication. Option D is continue both medication. So here the right answer is option B. We will DC his colchicine. So colchicine we can DC if patient have normal serum uric acid level for last 3 months, and if patient have no tophi on exam, if patient do not have any active disease. If patient have tophi or active disease, you can continue colchicine for up to 6 to 12 months till their tophi disappear. So if they are having acute attack, you might have to continue colchicine. If you give colchicine and allopurinol combination, they can have higher side effects. So we like to discontinue colchicine in 3 to 6 months after their uric acid level is normal, or after 6 months once their tophi disappear. So I already told you crystallization of monosodium urate crystal occur if level is more than 6 point. Our patient level is 5, so he's in good shape, so we can justify stopping colchicine. Question number 4. Xanthine oxidase inhibitor can be safely given to patient on azathioprine and 6-mercaptopurine. Is this statement true or false? This statement is false. Let's talk about this statement. So this is hypoxanthine and xanthine are metabolized into uric acid. So for this step, you need xanthine oxidase. Fiboxy Stat and allopurinol inhibit this enzyme. Now, xanthine is easily excreted from our kidney. So if you give them Fiboxy Stat or allopurinol, we will have a lot of xanthine in our body which we can excrete. Now, xanthine oxidase is also required for this step. It required for the for conversion of azathioprine 6-mercaptopurine to 6-thiouracil. Now, if you give xanthine oxidase inhibitor, these patients gonna have increased level of 6-mercaptopurine and increased level of azathioprine. So if you are giving these drugs, you might have to check their level, or you might have to decrease the dose. So it's not safe to give Fiboxy Stat, Allopurinol with azathioprine and 6-mercaptopurine. Let's do question number 5. We have a patient is on 600 milligram of allopurinol and he came back after 6 months. So this patient is on a very high dose of allopurinol. He came back after 6 months. He's on chronic prophylaxis for gout. His uric acid level is 10. So he is not responding. He had 3 to 4 attacks in last couple of months and he has tophi on examination. So what would you do for this patient? Option A, add probenecid. Option B, DC his allopurinol and start him on colchicine. Option C, DC his allopurinol and start him on pegloticase. Option D, continue allopurinol and start him on pegloticase. So here the right answer is option C. This patient, we will stop the allopurinol, we will start him on pegloticase. So let's talk about this question. Now, patients who are on allopurinol, if they are compliant with the medication and compliant with the diet, and if you are unable to control their uric acid level with 450 milligram of allopurinol, it means the medication is not working. So this is what's happening with our patient. Despite on a very high dose, his level is high, he's having attack, and he has tophi on examination. So we are not doing a good job with allopurinol. So I would stop allopurinol and start him on pegloticase. So what? Option D is incorrect. If you are planning to give patient pegloticase, you do not give any uric acid lowering drug. What happened? Pegloticase is a recombinant uricase enzyme. When we give this enzyme, few patients can have autoantibodies against pegloticase, and if you are giving them uric acid lowering drug, either allopurinol or Uric or Fiboxy Stat, they can lower the uric acid level. So you cannot find out whether patient lower uric acid level is from allopurinol or from pegloticase. So if you are giving pegloticase, it is a monotherapy. You don't want to give any chronic prophylaxis with this. If you are giving pegloticase, if patient uric acid level is very high, you should suspect immunogenicity. They might be developing autoantibodies, so you should not give them pegloticase because this patient can have infusion reaction. So that's why option D was incorrect. We're going to talk about option A in a couple of minutes, okay? So colchicine is only for acute prophylaxis. That's not going to help. This patient need chronic prophylaxis, so you need a combination of 2 drugs, okay? So the best option from this question was, best option is option C, okay? Now let's talk about what is pegloticase. So uric acid is metabolized into allantoin. Now this step requires an enzyme called uricase. This enzyme is absent in human. Uricase enzyme is present in mammal. So mammals do not have gout attack. We don't have this enzyme. So that's why we get gout attack. So if we can give recombinant uricase, pegloticase or respiricase. Respiricase we use for tumor lysis syndrome. If you are planning to give this enzyme, patient should have G6PD level check. These patients can have hemolytic anemia, okay? So allantoin is easily excreted from kidney. So our goal is to give them uricase from outside. So uric acid will be converted into allantoin and which will be excreted. So if you are giving patient pegloticase, patient uric acid level can go even up to 0, okay? So how do you do dosing? So one point, if you are planning to give patient pegloticase, patient should be referred to a rheumatologist, okay? So we give it every 2 weeks as 8 milligram infusion over at least 2 hours. You should check serum uric acid level before each infusion. Their level should be very low. Patients during this, if you are giving pegloticase, you have to give them acute prophylaxis either with colchicine or NSAID or low dose prednisone. You should not give allopurinol or any chronic prophylaxis drug. We already talked about that. So let's do question number 6. A 49-year-old male with history of recurrent uric acid stone. He's on low protein diet. He's making more than 2.5 liter urine, which is pretty good. We want patient with kidney stone to make more than 2.5 liter urine every day. Potassium citrate was started after third attack. He has a past medical history of diabetes and hypertension. His 24-hour urine calcium is 230, which is normal. Citrate is 400 milligram. Oxalate is normal, but his 24-hour uric acid level is very high. It is 880. It should be less than 750. What would you do for this patient? Option A, give him calcium carbonate. Option B, start him on allopurinol. Option C, start him on hydrochlorothiazide. Option D, give him probenecid. So here the right answer is option B. We will give him allopurinol. So allopurinol is indicated if patient have 24-hour uric acid more than 750 and recurrent stone. We are not going to give this patient probenecid. Probenecid is contraindicated if patient's 24-hour uric acid is high, if it is more than 800 milligram. Probenecid is not efficacious in CKD patient, and multiple daily doses is required. Patient needs to be well hydrated. So probenecid was wrong option in this patient. Now, hydrochlorothiazide is given to patient who have hypercalciuria. Our patient's 24-hour urine calcium is 230. So that drug is not indicated in this patient. Calcium carbonate is not indicated in this patient. So the right option for this patient is allopurinol. So allopurinol, so we talk about 4 indications for giving chronic prophylaxis. Number 5 is if patient is having recurrent uric acid stone despite hydration and alkalization, you should consider giving them allopurinol. And if patient uric acid is more than 1100 milligram per day in men less than 25 year or premenopausal female, these patients can have rare genetic defect. They make too much uric acid and they excrete too much. You can justify giving them allopurinol. One point I want to make is patient who have asymptomatic hyperuricemia, if they do not have gout, you should not give them allopurinol. Most of the patients who have asymptomatic hyperuricemia, they do not end up developing gout. So let's do last question. I think second last question. A patient come to your office, he's having acute gout attack. His GFR is normal. He has multiple joints involved. He has history of diabetes and peptic ulcer disease. What would you do for this patient? Option A, give him intra-articular steroid. Option B, start him on NSAID therapy. Option C, give him colchicine. Option D, start him on oral prednisone. So this patient is having acute gout attack. So we have to give him a medication. So here the right answer is option C, colchicine. So let's talk about option A. Intra-articular steroid are not indicated if patient have multiple joint involved. We typically give intra-articular steroid if patient have one joint involvement. You have to make sure patient do not have septic arthritis. NSAID can be given if patient do not have history of CKD or peptic ulcer disease or congestive heart failure. Our patient have peptic ulcer disease, so we will not give him NSAID therapy. What about oral prednisone? Oral prednisone is also contraindicated. This patient have diabetes, this patient have peptic ulcer disease. So the right option for this patient is colchicine. So patients who are older, they can have multiple joint involvement, they can have atypical gout. Most of these patients have underlying CKD or some kind of medical problem. So most of the time patients who are older, I end up giving them colchicine. Patients who are younger, most of the time they do not have any comorbidity, so you might give them NSAID therapy. So let's talk about treatment of acute gout. Treatment of acute gout and pseudogout is similar once you rule out infection. So there are 4 contraindications to NSAID which you have to remember. If patient have CKD, peptic ulcer disease, and if patient who's on oral anticoagulation and congestive heart failure, if patient do not have any contraindication, typically these patients are young, they have typical gout, you can give them NSAID. The drug of choice is naproxen and indomethacin for 5 to 7 days. Duration is shorter if you use within 24 hours. So the sooner you use acute therapy, the better patient's gonna get. When do you stop NSAID? We stop NSAID 1 or 2 days after clinical sign resolve completely. Okay, so typical course is 7 days of NSAID. Typically we give NSAID to younger patients who are male, who have typical gout. Now if patient have contraindication to NSAID, the next you can give them colchicine. Colchicine is contraindicated if patient have CKD or liver disease, if patient are using P450 inhibitor, patient is on azole or protease inhibitor. If patient do not have any contraindication to colchicine, so you can give them colchicine. You start colchicine sooner, just like NSAID, within 24 hours. Colchicine is not helpful if you give it after 72 hours. Just like the way we give acyclovir for shingles, Tamiflu for flu. So we like to give colchicine sooner, preferably within 12 to 24 hours, okay? Not effective after 72 hours. So how do you give colchicine? So if patient is not taking colchicine in the past, you give them 1.2 milligram followed 1 hour later by 0.6 milligram for total of 1.8 milligram on first day. After first day, you can give them 0.6 milligram once or twice daily as tolerated. We titrate it if patient can have diarrhea. If patient is not having diarrhea, you can go up to 0.6 milligram twice a day. So you stop the medication 2 to 3 days after complete resolution of gout flare-up. If patient is taking chronic prophylaxis of 0.6 milligram per day, we followed above regimen. Resume chronic prophylaxis dose 48 hours after flare resolution. So you are giving them 1.2 milligram twice a day, and after 7 to 8 days, once they're completely normal, you can go back to 0.6 milligram. Diarrhea and abdominal cramping are less likely if you are using less than 1.8 milligram of colchicine on day 1. Very important point, if patient is on chronic prophylaxis with allopurinol or Fiboxy Stat or Uric, you should continue those medication. You should not stop those medication. So last question, question number 8. A patient with acute gout, GFR is low, patient have stage 3 CKD, uric acid level is only 5, multiple joints are involvement, so this patient might have atypical gout. What would you do? Option A, Fiboxy Stat. Option B, NSAID therapy. Option C, colchicine. Option D is oral prednisone. So here the right answer is option D, oral prednisone. Fiboxy Stat is for chronic prophylaxis, so that drug is not indicated. Why we did not give colchicine? Colchicine have increased side effect in patient who have a CKD. Same with NSAID. So option B and C are relatively contraindicated in this patient because of low GFR. What about uric acid level of 5 in patient with acute gout attack? So patient who have acute gout attack, they can have normal uric acid level. So normal uric acid level do not rule out acute gout attack. Let's go back to our flow chart. So if patient have a contraindication to colchicine, if they have more than 2 joint involvement, let's say if they have only 1 joint involvement and you have ruled out septic arthritis, you can give them an intra-articular steroid. But if they have more than 2 joints, you can justify giving them oral, IV or intramuscular steroid. Just remember the contraindication. Some of the contraindications for steroids are same as NSAID. So we don't like to give steroid if patient have peptic ulcer disease, congestive heart failure. So with this question, we are done with this section. In next section, we're going to talk about how to distinguish gout from pseudo-gout. We will also talk about seronegative arthritis and seropositive arthritis. So I'm going to stop it here. Thank you.